All right, it looks like it's 11 o'clock, and I guess we'll get things started. Hey there, folks. How are you doing today? My name is Ben Kenny, and I'm publisher of Business North Carolina Magazine, South Park Magazine, and the North Carolina Tribune. Welcome to today's virtual town hall hosted by the North Carolina Healthcare Association. Today's program on creating healthier communities is part of a series of town halls that connect North Carolinians with hospital and health system leaders and offer opportunities to hear about some of the challenges, successes, and future opportunities for healthcare in our state. And today we're going to focus on the urban aspect of this, and we're going to hear from 5 healthcare leaders about how their hospitals and health systems blend medical know-how with community engagement and technology to help prevent and manage chronic conditions and to address factors affecting healthcare, like access to healthy food and transportation. We will discuss how they work with local employers, schools, faith organizations, and other partners to build healthier, vibrant communities. And now I'd like to introduce you to our panel. First, we have Dr. Cherie Gregory. She is the Senior Vice President and Chief Health Equity Officer for Novant Health. We have Dr. Keneal Coltman, Executive Vice President and Chief Community and Social Impact Officer for Advocate Health, which Atrium Health is a part of. We have Dr. Olu Jegede, Vice President in Clinical Care Health Equity at Cone Health. And we have Dr. Teresa Amerson, Chief Medical Officer, Population Health for Wake Med. And finally, we have Deborah Jones, Associate Vice President for Community Health at Duke Health. Welcome, everybody. A few housekeeping items. All lines are going to be muted throughout the program. If you have any technical issues during the webinar, please send a note in the question panel and we will assist you. Questions may be asked anytime by clicking the Q&A icon at the bottom of your screen. And we have a full schedule, but hope to be able to answer as many questions as possible today. And we'll get on with our conversation. We're going to break this into topics a little bit. And the first topic we're going to be talking about is prioritizing community needs. So as we all well know, hospitals provide more than just health care. They're often anchors in their communities, providing jobs, driving the economy, and partnering with local entities to make community members healthier. Besides being the go-to source for healthcare, what role do hospitals play in their communities with respect to creating or improving health? And why is it important for hospitals to be involved in their communities? And Dr. Gregory, I'll let you kick this one off, and then we'll kind of throw the question out for other folks to add on.
Thank you, Ben. So health doesn't begin and end in the doctor's office or in hospital visits. It's really impacted by factors that may lead to someone's chronic health problems, behavioral health problems that actually exist in the communities. Some of the best ways to improve and advance health equity is to be a trusted partner in healthcare delivery. Hospitals and health systems really need to be involved in the communities because it's the best place to connect and create those most trusted relationships. And it's also the best place to listen to communities, to hear what they're experiencing in their environments where they live, work, pray, and age together. We know that social determinants of health impact 80% of what happens to, a part of 80% of what happens to patients and communities. So it's really important that we're present, not just to increase the quality of healthcare by meeting people where they are, but also to really understand what impacts their everyday lives and how we might be able to contribute to that work. We often talk about community health needs assessments, and one of the things that's important is to understand what the community needs are, as well as the individual person's needs. It's really a way to co-create together what those relevant programs need to be, and in order to do that, we really need to be in the community.
I love what you're talking about listening, because that's very important just in the healthcare industry, being a sounding board, talking to patients and listening to them. That's like, it's a big part of the process. Anyone else want to chime in terms of the impact of hospitals and health systems in the community?
I do, Ben. I could not agree more with what Dr. Gregory said. Good health actually begins in community. And I know that as a health system, we tend to focus on healthcare delivery, and we forget the other dimensions of our roles as an anchor institution. We not only provide health care, but we are an employer. So we have the opportunity to strengthen economic stability in our community. Our workforce makes up a pretty sizable portion of our community. And so we need to be looking at economic mobility for our employees. We are also a landowner as we think about what the needs are around affordable housing in our community. We're the procurer of goods and services. And so we have an opportunity to have a major impact on small and minority businesses in our community. And so it's really important to think about those other roles as they map to the needs in our community that we learn about, as Dr. Gregory mentioned, through the community health needs assessment and other listening sessions.
Great comment about the economic impact from that standpoint. Always a major employer healthcare systems are in urban areas, and even in our rural areas. Sometimes they are the top employer in a lot of them from that standpoint. Anyone else like to chime in on the community impact?
Okay,
Yeah.
go ahead, Doctor.
Oh, I was going to add, I mean, after agreeing with what Dr. Gregory and the other speaker mentioned, that a significant part of our community is to actually trust us, trust the health system, to be able to come access healthcare and follow their treatment plan and engage in preventive care. So this cannot be achieved, the trust cannot be achieved if you are not in the community. We need to be there, partner with the community-based organizations and the people in the community, because of course, healthcare and treatment is a partnership, right? So we want to be there to earn that trust so they can come to us and seek healthcare services.
Go ahead, Dr. Coleman.
Yeah, I was just going to add, since the topic of affordable housing came up. So when Atrium Health in the Southeast and Advocate Aurora Health in the Midwest came together 10 months ago, we made the choice to prioritize health equity as one of our key pledges as part of that combination. And so as part of that, we're building an Advocate National Center for Health Equity, where we're focusing on disrupting the root causes of health inequities. Obviously, you know, we all understand that we've got to prioritize getting it right in terms of delivering equitable care in our clinical settings. But I think today is really about what happens more in our spheres of influence. And so I just wanted to point out, you know, Fast Company ran an article this morning, and it was entitled "Charlotte's Brilliant Plan to Save Affordable Homes is a Blueprint for Other Expensive Cities." And if some of you read that, it's about the Housing Impact Fund, which was sort of a public-private partnership fund that helped cull together funding to be able to buy and preserve naturally occurring affordable housing communities that were already in existence. But in a market like Charlotte, if you don't preserve these affordable housing complexes and they get snapped up by developers, rent rates shoot up, and that causes displacement. We know that has impacts on health. So Atrium Health made a decision early on to be an angel investor in that fund. They've just done their second round of funding. So between those two rounds, they will have been able to preserve 800 units in the first round, another 1,200 units in the second round. We've made similar investments in the Winston-Salem area in Metropolitan Village, and we're using not community benefit dollars, but actually our balance sheet dollars. So as we think about, you know, how you invest in markets, yeah, you could put your money in the stock market, or you can use your investment dollars to drive social good in the community. And so that's what we've made a decision to do. And I think that's a lever that a lot of health systems can play, in addition to being a role, as other panelists have named, around being a great employer that has an economically stabilizing impact on the community. Also figuring out, how do we play in that space of preserving affordable housing? Because we know when people lose their housing, health deteriorates.
If I might add one last thought, Ben, and then I know you want to move us along to the next questions. It occurs to me, thinking through kind of patching back onto health systems as employers and kind of the largest employers in some cases in a community, thinking about futures of community is also important, and a place that we can contribute. And what I mean by that is thinking about offering, how do we offer future financial stabilities in the form of jobs for folks in our community, and really reaching into and partnering with local schools, local universities, local technical colleges to really firm up a pipeline of earlier education for communities, offering that chance to bridge that gap and to partner with our health system so that there's a clear pathway of advancement for folks who might choose to stay in our area and contribute in our organization in the future. But really looking forward, not just at how do we partner with our communities right now for current day, but how do we also put some programs in place that might help the future and some of the kids coming up.
That's a great point. That's a great point. For our next question, every community is unique and has its own set of challenges, of course. How does your hospital identify the specific health needs of the community? How do you use this information to develop initiatives and to address social, economic, and environmental issues your community faces? And we'll go right back to you, Dr. Amerson. Can you tell us more about WakeMed's new Center for Community Health Innovation and Equity, and how your team decided this approach was necessary to meet the complex and diverse needs of residents in Southeast Charlotte?
Southeast Raleigh, but yes, I'd love to.
Sorry. I'm
No
going to hear that from statewide. Charlotte folks, Southeast Raleigh, my bad.
No problem. I'd love to. So our Center for Community Health was really kind of born out of probably about 10 years now of various population health strategies that we've put in place to help our most vulnerable patient population here in Raleigh. And we're fortunate that we live in a community in a county that our hospital systems and all of our hospital systems and our community really have banded together over the years to kind of support each other and really focus on kind of those patients in our community that are suffering the most. And oftentimes kind of their utilization of the healthcare system is probably our first indication, or one of our first indications that these patients are just really suffering and aren't connected in a way that they might benefit from. So the Center for Community Health, we opened as a physical location in October of 2022, so almost a year ago. But it brought together kind of our best programs using data analytics to identify those high risk or vulnerable patients who are suffering the most in our health systems, and really bringing them into an alternative location with a fully collaborative, integrated team that could more appropriately kind of wrap care around them to really stabilize the experiences that they were having and figure out what community resources were going to support them in the long term going forward. So the cool thing, the thing that we're super excited about with this particular model is just the complete 360 collaborative nature of it. So not only in the health world do we have a fully integrated health team with primary care, psychiatry, counseling, trauma-informed counselors, spiritual care, intense case management, all of those pieces that we can do to bring the best of healthcare to a patient. But we also partner with our community safety net clinics to find patients a good, well-established medical home that fits their needs the best in the communities that they live in. And then we wrap all of that with collaborative partnerships with community-based organizations to fulfill some of the social needs and gaps that we're finding. So far, we've seen 1,300 patients this year in the center, which we're really excited about. 113 of those in kind of our most intensive 90-day model, and then the others in a less intensive model. But we're really excited to see what that center will continue to help our community really just embed patients and relieve suffering.
And how long has that program been in place?
This particular program, the center, the physical plant, has been there almost a year, but some of the pieces and parts were nomadic programs before. So our community case managers literally backpacks on their back and out they went without a physical plant to see patients in. So those programs are now housed in the Center for Community Health, so it gives them a home and a central place to work out of. But we still have folks with backpacks on their backs meeting patients where they are as part of those programs.
That's awesome. That's awesome. Dr. Jigede, can you explain Cone Health's Catch 5 and 5 initiative and talk more about the link between life expectancy and where a patient lives? How did your team use this information to improve the health of people living in certain zip codes?
Thank you, Ben. In I think it was 2022 September when we published our community health needs assessment. This assessment identified significant areas of existing disparities in our communities that affect the health and wellness of the people in our communities and in our service areas as it relates to life expectancy. So we took a deeper dive in this data and find out that there is 15-year life expectancy gap between zip codes that was separated by about 15 minutes drive within a 5-mile radius of our major hospital. So we also looked at why people are dying younger in these zip codes. And there are 5 major life expectancy drivers. These are cardiometabolic diseases, which is really around uncontrolled hypertension, congestive heart failure, diabetes, stroke. And of course, the second one is cancer. People are not getting screened early enough. And then infant mortality, opioid overdose, and violence as it relates to homicide. And when we brought all this together, it's actually the communities that have been historically marginalized, that have not been, they don't have access to healthcare, no access to a lot of the social drivers of health, financial security, poverty, housing, food insecurity, and so many things like that. So we call our program Catch 5 in 5. And this is in relation to our goal of reducing this life expectancy gap by 5 years in 5 years. We chose 5 years because we know from data and research that when you control for the cardiometabolic diseases like control blood pressure, control blood sugar, smoking cessation, and reducing overweight or obesity, that you can give 5 years back to people's lives. So we know this can be done within 5 years. And we call our program Catch 5 in 5, which stands for Collaborative Actions Toward Community Health, to give 5 years back in 5 years. So this plan really details how we will operationalize a community outreach program using our screening and education as a powerful tool to reach the communities and to impact health disparities for these patients that are experiencing lower life expectancy. This program actually, we kicked it off in July 8th, where we partner with over 70 community-based organizations. We call the program Building a Better You. We served a lot of our population in the communities attended this event. People went home with solutions to their housing issues. A lot of food were handed out and resources to connect them with the community on how to navigate all the resources available that they were not even aware of, were all given to them. People asked questions and their questions were answered. We also use that opportunity to ask feedback, what do you need? Because a lot of the time we don't know what the community needs. So we use that to get feedback from them on how best can we serve you. And again, going to Catch 5 in 5 is collaborative efforts. So we know that we have to partner with a lot of our community members, community-based organizations. We have a memorandum of understanding with the City of Greensboro, working with them on all these initiatives. We also have one with NCHA University on training workforce and also hiring local and pulling people out of poverty. We have a partnership with UNC Greensboro also in training nurses, and a lot of other initiatives that we're going to be doing in the communities to bring people to serve to healthcare, serve them as preventing ED utilization where care is really not optimal, connecting them to primary care, screening those diseases that may sneak into them. And by the time they come to our healthcare, it's almost too late. So we want to make sure that we are connecting people to care. and getting those chronic diseases managed on time.
The preventative is so important for sure. If I may ask, does anyone else have something they'd like to chime in terms of how you're addressing these community issues from that standpoint? Good. Okay, well, we'll move on to the next topic, which is apt collaboration and innovation. Hospitals collaborate with community partners to improve the health of communities. Can you discuss a few key community partnerships or collaborations that have been particularly successful improving the health in your community? Ms. Jones, if you can start by telling us about Duke Health's partnership with the AME Zion Pastors, Home Equity Advocates Liaisons, and how it's helping to rebuild trust in healthcare among the Black community.
Absolutely. Dr. Jagetti mentioned earlier the importance of trust, and probably no more trusted stakeholder in our community than our churches. The AME Zion Church and other churches have a long-standing history of working on equity, justice, civil rights in our community. They are places where people feel cared for, and they trust the information that is dispensed from our churches and disseminated from our churches. We have the great fortune here at Duke to be an academic medical center, so we benefit from our academic colleagues and researchers. And about 6 years ago, the Clinical and Translational Science Institute started this program that we call HEAL, which stands for Health Equity Advocates, Advocate Liaisons. And they partnered with the AME Zion Church. This is actually led by Dr. Nadine Barrett, who is the director of the Center for Equity in Research. And what I love about this program, when we talk about any type of partnership, it's important to really look at reciprocity. Sometimes as a health system, we can feel like the 800-pound gorilla in the room, and power dynamics can be a bit of a challenge, but we are sharing knowledge with pastors, 17 pastors as a part of the HEAL program, but they are sharing their cultural knowledge with our researchers, enabling them to be far more effective and more respectful of community members as they are approaching them, soliciting and recruiting their participation in clinical trials research based on a lot of the issues that we have with underserved populations participating. Just one example of that, kidney disease is more common amongst African Americans, and yet less than 5% of African Americans participate in clinical trials. And so pastors are helping us get the message across, educating their congregations, helping to recruit, and they're also leading by example. They are participating in clinical trials, so they are practicing what they preach literally in this program, and it has been highly effective.
That's incredible. It's awesome. Dr. Gregory, can you talk about Novant Health's partnership with UNC Health to develop a new psychiatric residency program? Why is building a robust healthcare workforce, especially focused on behavioral health, so important right now?
Thank you, Ben. When we looked at social needs surveys, we did over 52,000 of them between 2022 and entering into 2023, and we administered those in ambulatory and acute settings. Food insecurity, financial strain, transportation, and especially stress and mental health arose in our patient population. And we know that for behavioral health specialists, we desperately need them in the region and across the state. COVID pandemic really increased the need for mental health services. Just recently, we were able to connect with UNC Health, UNC School of Medicine, and the Naval Medical Center Camp Lejeune to launch a new psychiatric residency program to train more physicians. We realized that there aren't enough specialists in the pipeline for us to be able to look to having specialists in North Carolina. And that was really important to us. This will help us to create the next generation of mental health specialists in our areas. And what's really incredibly unique about this is we got ACGME approval to have a military civilian residency. And there's only a handful of those in the country. So what that looks like is we will have several civilian as well as military residents partnered together over a 4-year program starting in 2024. And they'll complete their residency rotations both in the New Hanover Medical Center for Novant Health, as well as the Naval Medical Center. So they'll have an opportunity to really take care of diverse patient populations, and especially have training in unique needs for veterans like post-traumatic stress disorder and head traumas. One of the things that I love about this program is that when the residents leave, they often will stay with us. So we have a real track record of having over 50% of our residents from our residency programs stay in North Carolina and stay in the area. So we're hoping to be able to continue to increase that pipeline. And then for our military colleagues, they will be able to care for patients globally. So this will really impact urban areas, rural areas, and also have a global impact.
Great way to recognize the impact of the military too in our state, which is also such an important part of our economy for sure. We've got time for one more question in this kind of round, and then we'll go to something else. But I'd like to get to topic number 3 so we can cover all our topics, if that's okay. The next topic is looking towards the future. A community's needs are constantly changing. What steps does your hospital take to ensure your programs and initiatives are evolving to meet the needs of the community you serve? Are there any new directions or areas of focus that are being considered? And Dr. Coltman, I'll go to you. Atrium Health recently expanded its Drive to Thrive initiative to reach women in underserved communities. Can you talk about how this initiative has evolved to meet the needs of the community and combat barriers such as transportation, language, and lack of insurance?
Yeah, sure, Ben. So the idea of this unit was actually born out of, and we've already touched on it today, just really glaring and completely unacceptable disparities in infant and maternal outcomes in particularly communities of color, but also underserved communities in general in North Carolina. And so I think a lot of folks know these stats, but 1 in 10 newborns in North Carolina are born premature. If you look at preterm birth rates for Black infants, it's nearly double that of other race and ethnicities in North Carolina. So these are really pronounced disparities that we need to kind of run at the root causes of. So the Drive to Thrive Women's Care Unit is, to our knowledge, the nation's first unit dedicated solely to women's health care. And it's the first of its kind in North Carolina to bring OBGYN care specifically to underserved communities. We've staffed the unit with a physician or an APP, depending on the day, advanced practice provider, I shouldn't use acronyms, a social worker, and a bilingual medical assistant, because we want to make sure we're really reaching all of our communities. We also have virtual interpreter services equipped on the mobile unit. But that's really to ensure that we're providing linguistically concordant and culturally affirming care. And then we're also assessing the patients for their SDOH needs as part of that whole practice model. During the early operations of this unit, nearly half of the patients requested and received some form of long-acting reversible contraception. We call that LARCs. So that's helping to prevent if a woman doesn't want to get pregnant, we want to support her in making that decision. And so those are part of how we're serving communities that may struggle to have access otherwise. About 50% of the patients that we've seen today are uninsured, and the other are largely government payers. We're so pleased with the impacts of this model that we're actually looking to expand it to the Midwest. And this is in addition to a fairly robust mobile primary care fleet that we've lifted off thanks to wonderful philanthropic partners such as Truist, the Tepper Foundation, where we're using kind of GIS, Global Information System, mapping system to understand where our highest burden of chronic diseases are in our most underserved communities that may be challenged with access, and being able to take essentially a clinic on wheels to that community. So we're doubling down on that model and figuring out how we can grow the footprint. Obviously, it's a tool for urban communities, but we also think for rural communities as well.
It's awesome. Thank you. Dr. Emerson, Wake Med saw the community's need for behavioral health sciences, and in response, they announced a 150-bed mental health and well-being inpatient facility that's going to focus on the whole person health. Can you tell us more about this facility and the impact it will be having on the surrounding community?
Yeah, I'd be happy to. Shouldn't be a novel concept, and I'm sure to folks here it's not, that whole health includes chronic disease states and physical health as well as mental health. But more and more we're seeing a greater call from our community to really support them in mental health journeys. Just our emergency departments, I have a couple of stats for you here just to tell the story here in Wake County. But in 2022, our emergency departments admitted 4,000 adults and children with suicidal ideation in 2022. That's a 15% increase from the previous year. Similarly, our EDs saw a 104% increase in pediatric patients who presented with substance use from 2020 to 2023. So our communities are suffering probably across the nation if we hear the stats, but certainly here at home, and thinking about how we wrap care around the whole person for their whole health is really what we're trying to conceive of. So our first whole health campus is set to open hopefully sometime in 2026 in the Garner area, and we'll have, like you mentioned, 150-bed hospital focused on mental health strategies, and then a 45-bed acute hospital there on the same campus. We're really focused on bringing to the town of Garner and our local areas a campus that really reconceptualizes mental health care, a facility that is beautiful, that is trauma informed. Kind of gone are the old days of we conceive of locked units and mental health facilities that may not have been the most welcoming and the most healing. And we're really striving to change that perception so that we can really focus on patients receiving all of the care they need to be their best self and their most healthy self. It'll be a place for all ages, so there will be programs for children, for adults, and for geriatric populations that are specialized mental health programs, but also chronic disease and acute care as well. So we're really excited to partner with the town of Garner. It'll be part of their 220-acre whole health and wellness campus there. So not just our hospital, but really a partnership with the community of Garner and the businesses, residencies there, as they're looking to really impact the health and well-being of their entire community. So we're excited, 2026.
Very, very cool stuff for sure. Folks, what we're going to do now is we're going to take some questions that were pre-submitted from our audience. And I'll just kind of throw this out there, and whoever wants to jump in on it, please feel free to, and we'll do the best we can to manage it from that standpoint. So our first question is from Camille in Durham, and she asked, how are you or your organizations including the community voice in the planning and decision process? Who'd like to tackle that one?
I would love to share just one of our initiatives here at Duke Health. We call it CASHE, but it stands for Collaborating to Advance Clinical Health Equity, and it's actually a data science analytics platform that uses clinical outcomes, and we're identifying the inequities that exist in those clinical outcomes and developing interventions. And what's really exciting about this particular initiative, we are working with community partners on the front end. I know that Dr. Coltman had mentioned maternal health rather. So maternal morbidity has been one of the areas that we have taken a deeper dive in, working with a community-based organization to better understand some of the nuance involved with the disparities that we see. So not only working with community partners to understand more deeply what's happening, but also working with them to design the interventions, what we can do to address those inequities. And our community partners brought up issues like aligning the bus schedule with the appointment schedule, wanting more culturally competent midwives, more doulas, more comorbidity care coordination. And we have actually implemented several of those strategies, including the alignment of the bus schedule with appointment schedules, and saw a significant uptick in our patients attending their third trimester appointments, and really have enjoyed that partnership with our community to really improve those health disparities.
That's great. Is there anyone else that would like to talk about the communication with the community efforts?
Yeah, I'd love to add a thought. Harkening back to the foundations when we created the center and moved into our Center for Community Health, part of that was recognizing that across our health system, but specifically with the center, we would really benefit from the partnership of a community advisory board that was really rooted in kind of the local area and the zip codes that we were trying to serve. So building that kind of robust community-based advisory council and really taking all of our thoughts and bright ideas and things that as healthcare providers and health systems we're really great at continuous process improvement and seeing something and having an idea of how we can affect it, but making sure that we're taking those thoughts and those ideas to respected members of our community who are really embedded in kind of all of the resources and the work that it would take to really impact overall well-being, and running it by them and seeing what they think instead of kind of doing what we typically would do without that perspective and just try something and see what happens. So that's been a great sounding board for us and has helped us to learn about exactly what does our community need and how might we affect that change in a way that really resonates with the folks we're trying to serve.
Once again, extremely important in terms of listening. Yes, please.
Yeah, I'd love to dovetail on that. So as I hear my colleagues talking about how we connect to communities, there's so many different ways that we need to do that. One is to have those congregation partnerships, to have community partnerships in other areas like libraries and parks and recreation, as we do, where we're meeting people where they are. And having that committed partnership actually helps us to better understand what patients need. So for instance, for our Michael Jordan clinics, much of how we designed that fully 360-degree integrated program was around what community members told us that they needed. Understanding what the social determinants of health were helped us to integrate behavioral health services, embed a social worker into our Michael Jordan clinics, be sure that we have integrated into that space community health workers, people who actually live in the communities, who can connect to people who are coming to those clinics and be able to understand not just what's happening at that clinic setting, but to be able to call them on the phone and connect with them. So it's this constant feedback. So we don't just set up a resource for you and send you on your way and wait till your next appointment, but actually connect with you in between appointments so that we understand whether that referral was the thing that you needed the most. We have patient and family advisory councils, and we also have LGBTQ plus community members who have joined voice councils with us, and disability has been a big focus of ours as well, where we have families and patients and leaders of communities with disabilities that help us to understand the experience that they have in our clinical spaces and how we can better be a resource to them and meet them where they are. So it really has to be that multi-pronged approach to connecting to communities in order to hear them listen and then understand what kinds of resources we need to put in place rather than kind of meeting together and creating it without actually hearing that community voice on what it's supposed to look like.
Great point. Let me move on to this other question we have from Cindy from Morrisville. How are your urban-based health systems working with rural areas to create healthier communities? Which is a great question because a lot of you all are reaching out and going into those some of those rural communities as well. So who'd like to tackle that?
Then I can take a swing at it. Currently we serve 57 rural counties across 5 states. And then in North Carolina specifically, about 1 in 4 patients who live in a rural area receive their care from us. So, we're the largest provider of rural care in North Carolina. So this is a big deal for us. We actually assembled a multidisciplinary task force to kind of refine our strategy around rural care, because we do think that we need to bring tools, learn from what we can in rural areas, urban areas, but sometimes the tools need to be different in rural areas. So we focused on, increasing access by addressing key provider shortages through focused training and educational programs. One is around just disparities, looking at our overall health disparities in data infrastructure and looking at it with the rural lens so that we can start to highlight what's different about a rural disparity versus an urban disparity, and then how can we start to laser focus programming and intervention around that. And then just sustainability. If you look at sort of the vulnerability of access to care in rural communities more generally, we're seeing unprecedented closures of rural hospitals across the country, particularly if they're freestanding. So part of our goal here is just to keep our rural hospitals open, thriving members of our community, and make sure that their clinical offerings are robust, but also finding ways to provide access to specialty and subspecialty care through some of our virtual behavioral health, virtual stroke, virtual other programs that we know that we can bridge that gap in access to specialty care using our broader virtual health infrastructure. We've also built a rural health residency program where we're really trying to grow our own in terms of rural providers that are really committed to this work. We placed 18% of Atrium Health residency physicians in rural North Carolina counties. The majority are in family medicine, which is desperately needed in rural areas. We've really ramped up our commitments to also nursing workforce. We have 6,500 nursing and allied health professionals and 2,000 MD advanced practice provider visiting learners that are rotating through the enterprise in rural areas. So this is part of our work with Wake Forest School of Medicine as our core. And then the last point that I'll make on this one, because it was about bridging urban and rural, is we actually piloted some of our school-based virtual care models in Cleveland County and refined that model in that rural community. And we saw how it was reducing school absenteeism. It was reducing unnecessary ED utilization. And then we actually scaled that to an urban community. And so now we have a wonderful partnership with Bank of America and Charlotte Mecklenburg Schools and Levine Children's Hospital, where we've scaled that program to 106 schools in 10 counties across our footprint. We're getting upwards of 10,000 visits and 10,000 unique patients. We've seen a 32% reduction in ER visits, saving over 332,000 in avoidable charges. So those are the kinds of, I think, novel solutions that working from an urban core, you can actually solve big problems in rural communities as well.
Yeah, it's listening and being proactive as well for prevention, which is great. Does anybody else want to chime in on kind of the rural urban relationship?
Yeah, I'll just add that for Cone Health, right now we're exploring a workforce development initiative in those rural areas. We served about 5 counties, and one of them can be categorized as rural. And community health worker is the way we're going to kind of serve the community. We're also using our mobile medicine to go into those rural areas to provide access to care, because a lot of the time there are no primary care access. So using the mobile medicine to do that is one of the ways we are doing it. And then we are doing a lot of partnership with foundations. We are very blessed to have Duke Endowment Fund on our side, granting us funds to really serve those the rural areas, especially around food insecurity and housing. So those are the kind of things we're doing. Really, mobile medicine providing access to primary care in the rural areas.
That's great. That's great. We have another question here from Marissa from Charlotte. And Marissa asks, what types of investments is your health system currently making in communities to improve outcomes at a system level?
I'll take that one on. You know, it's a really interesting question, because I believe that the change has to start with us. It's difficult to tell others how they must change, especially if we're talking about structural racism policies that drive the inequities that we are seeking to eliminate. I know here at Duke, we are fully invested in a number of leadership programs around diversity, equity, inclusion, and belonging, addressing topics around implicit bias, microaggressions, wanting our workforce to serve as an example and as a model and as advocates in the community for what needs to change. And there are significant investments being made right here at Duke Health. Additionally, looking at our policies, when I talked about those different dimensions, those roles that we must play in our community, we have to examine those policies and see what types of barriers we have put in place that might be contributing to the inequities that we see in our community. And beyond that, we are working in collaboration with a whole host of community partners. Dr. Coltman mentioned an angel fund, and we've been making very sizable investments with our partners in a lot of those areas that we've been talking about, housing and education and economic development, to really drive what we'd like to see in our community.
That's great. Would anybody else like to talk about investments being made?
I'll dovetail on that. So one of the things that we realize, as my colleague just said, is part of the investment has to start with our team members. And when we think about systemic racism and how we address it, it can't just be a community or computer-based learning. It really has to be a culture change strategy. And one of the examples that I'll give you is we have a long-term goal for maternal and infant health equity that looks at making sure we have early prenatal care as well as adequate prenatal care. Also addresses the social determinants of health of birthing persons. And one of the things that's really important is that we've leveraged our learnings from when we instituted safety initiatives around our organization. So long before COVID, we would be sure that we would have a safety question or a safety topic at the top of every meeting, interwoved into our conversation. So when we entered into the pandemic, we actually saw a decrease in safety events. We thought that that was best practice. So one of the things that we do now is we also have interwoven into our conversations in our clinics for women and children, a conversation around how to potentially mitigate the impact of implicit bias and to give each other examples and to hold each other responsible for being able to look for those opportunities where we see that we could do better in situations around diversity, inclusion, equity, and belonging for our patients. It's been an amazing journey. Our advanced practice providers and our physicians have all agreed to be on this journey with us over the course of a year and a half to really begin to understand how we show up for our patients. And more importantly, added to that are community conversations. Once a quarter, every quarter, we connect with communities to hear about what their personal experiences are as they're raising their children and as they're having children in our facilities, so that we can continue to hear that community voice as we grow together.
That's great. Dr. Gigetti?
Yeah, if I can add, as part of our leadership commitment, this is the second year in a row now that we are actually intentionally working on closing the gap in hypertension control as a true north metric for the system. So everyone is involved, and in fact, last year we closed that gap not only up to 70%, but we actually exceed the national benchmark for hypertension control. And we also now, as a strategic priority, call out healthy communities as part of the 4 major strategic priorities. So this is how Cone Health is investing intentionally in health equity and closing the gaps between our service areas. Also, I mean, somebody mentioned, I think it was Dr. Jones, around policies, looking at our policies and looking at them, through the lens of health equity, making sure that we are not unintentionally building disparities in those, or health inequity in those policies. So those are the areas that we're working on.
That's great. Would anybody else like to comment? Well, I'll tell you, we're kind of we're at a time period where I kind of like to get everybody's it's a personal question in terms of each one of you. I'd like to give everybody to answer this, but I think it's kind of a neat way to kind of round things out here. Dr. Gigetti, I'll start with you. We'll ask everybody this: what led you to go into a healthcare career?
Oh, that's a childhood story for me, actually. Growing up in the church, there is this very great man that always come to share the great works they are doing in the city. And every time he comes, they introduce him. We bear the same first name. So he will be introduced as Dr. So-so, and then they will talk about every great thing he's been doing, helping people, healing people, treating people. And it just looks so great. And, bearing the same name, since then, I think I was 6 years or 7 years old. I want to be like this man. When I grow up, I want to care for people. I want to be introduced with this enthusiasm when I show up. And so since then, I work towards being in healthcare, and I'm grateful that I have that privilege.
That's great. Dr. Coldman?
So we've been talking about rural urban communities. I grew up in a very rural part of Western North Carolina, and my first semester in college, I had the privilege of participating in a semester-long dialogue on racism. I was still 17 at the time. I needed to figure out what I wanted to be when I grew up, but it was a collaboration between the local university and the local health system. So I was in there with a lot of healthcare professionals, and it was just a life-altering experience for me. And that's when I made the decision. I approached the university, asked them if I could create my own concentration in diversity in the business school. And then I graduated and couldn't find a job at a health system in my home state working on these issues. So I ended up at a health system in Texas. But I think throughout my career, the common thread has been to focus on systems of injustice and to figure out how we can start to reformulate the system so that it delivers on justice. And that's, what the work that I get to do to this day, and I'm very grateful for it.
Well, we're glad to have you back in North Carolina. Glad you found that position here, right?
Took me a while, but I got back here.
There you go. There you go. Ms. Jones, tell us a little bit.
Oh my goodness. So I started my career wanting to pursue law, wanted to serve as an advocate for what I considered to be the voiceless, and ironically ended up in computer science. So computer science and analytics is my background. I was in business for myself for about 15 years after working for IBM, SAS, Institute, and other places. But my father ended up getting really sick. He was an associate provost at NC State. And it really struck me how uncomfortable he was, not communicating what his therapy desires were with his provider. He was uncomfortable sharing that, and he was a speak truth to power type person, and yet not comfortable sharing his desires with his provider, and that really struck me. And one of my clients at one point said that my messages through the consulting work that I was doing in community outreach, she said, your messages really touch the soul. And it was in that moment that I felt like healthcare chose me, wanting to serve the community and be that servant leader.
Great story, without a doubt. Dr. Gregory.
So I'm told that before I could remember, I always wanted to be a doctor. And I think the part about health equity being everything that I love most about medicine happened in medical school. I was a first year, and I had a disproportionate, according to the dean of students, a disproportionate number of people die in my family. And I was called to the office and asked to bring the obituaries to prove that those events actually happened, because my experience seemed so unique in comparison to some of my counterparts. And I realized that why we were having this conversation was because I had family that lived in Eastern Carolina and family that lived in urban New York, in Brooklyn, and their access to care was different. Their chronic disease was different. So I had a cousin die at 33 years old from heart disease, and aunts and uncles. And it became very clear that part of what I needed to do was to teach people to understand how health equity and the lack of it really impacts not just the individual patients, but the entire family around them. So I missed much of school in that first year because of a disproportionate experience of health equity or a lack thereof in my family. And so being a doctor was something I always wanted to do. As I began to go through medical school, I realized that not everyone had the same access to care. So I would discharge moms with children, and we'd have to find a homeless shelter for them to go to, and not really having anybody that would spend the time to have that conversation with patients. And so that's what drives me every day, to be able to create systems that we have in place, like our community health workers and our social workers and physicians and APPs and clinical team members that want to hear that conversation, that want to understand not just how health equity is impacting the patient, but the entire family and the community around those families. And that's what's been really important to me in my career.
Still a big driving force, I'm sure, without a doubt. Sure. Dr. Emerson.
So I had a little bit of a different pathway, circuitous and kind of tangential, but I was a Girl Scout when I was a kid. And one of the kind of prime values that got instilled in me is always leave things better than you found it. And that just resonated kind of as I went through my educational career. I was a bit of a science geek throughout all of it. So landed at NC State, majoring in biochemistry, thought I was going to do bench science work, and had some experiences doing that in some labs, and really figured out one day that it was just me and my pipette, and there was nobody to talk to, and there wasn't going to be a kind of an immediate, how did I make somebody's life better today with that work that I was doing. So I started looking around and thinking about other things I could do, and just had this epiphany that, you know, people's lives stop when they're not doing well, when they don't feel well. Their whole life just kind of comes to a stop. And that's when I decided, you know, all of these things married together, leaving somebody better off than you found them, and really helping people get through the worst parts of their life. That's the privilege we get when we're physicians. And so that's what prompted me to go into caring for people as a primary care doc, and then thinking about how can I make systems and populations better than I found them. Kind of was a natural trajectory to lead me to the role I am now.
That's awesome. Great story. I will tell you, hearing your stories, your background, as well as the answers to your questions, I can tell that each and every one of you is very passionate about what you do. And as someone that we report on business in North Carolina, healthcare is incredibly important to the economy, and lots of times we hear a lot of bad news about things like that as well. But when we do these type of roundtables and we talk to leaders in the area and see the passion, it makes you feel a lot better. So I really appreciate you all taking the time to talk with us a little bit about this as well. So thank you all. Just once again, Dr. Therese Gregory, Dr. Keneal Coltman, Dr. Jigede, Dr. Amerson, and Ms. Jones. We really appreciate y'all and what you do for our state, without a doubt. I'd like to thank everybody in the audience. Just quick, once again, housekeeping. If your question was not addressed today, please send an email to communications@ncha.org, and the NCHA will reply back to you. A recording of today's conversation will be available for viewing or listening at nchealthcare.org. Feel free to share the recording with coworkers, students, and others. It's inspiring. And again, the website is nchealthcare.org. Now, this was the first portion of this. So join us for part 2 of this conversation focused on rural communities on October 11th at 11 a.m. That conversation will feature representatives from the North Carolina Rural Center, Iredell Health System, ECU Health, Northern Regional Hospital, Onslow County Memorial Hospital, and Mission Health. And you can learn more and register for that event by visiting nchealthcare.org/events. My name is Ben Kenny, and thank you all so much for attending. Have a great week.